And let's start now with the ovulation induction in non-IVF cycle. One of my most favorite and most important topic of a discussion, which is of interest to each and every gynecologist. I welcome you all. Now, ovulation induction for a IUI, what we do is which are the indications? Mainly, it's in a polycystic ovaries, unexplained infertility, endometriosis, and the male subfertility. These are the patients in which we, in a non-IVF cycle, we do the ovulation induction when we want to time the IUI. So I will be talking with you with my experience, with the evidence, and what are the presentations patient come with, and how do we work. We all know with the birth of a first IVF baby, 25th July 1978, and further in last more than now 4 decades, so much of advancements in the field of reproduction has happened. The advancement in understanding our subject, the physiology and endocrinology of a follicular phase, ovulation, and luteal phase, advancement in the technologies with the injections, gonadotrophins, oral ovulagens, and advances in the ART laboratory procedures. So more or less, we are trying to send our couple more happily with the fruitful results. Just give me 1 minute. Will you tell Hemlata not to do any noise there? So what are our goals of ovulation induction? So you have to first decide whether she's unovulatory and your goal of induction is to make her ovulate, or she's ovulatory, she has a regular cycle, and you probably want to optimize her ovulation. There may be a subtle defect in a follicular phase and a luteal phase, and you wish to put that you wish to improve in a ovulatory woman. So most important, our goal should be to induce a monofollicular than a multifollicular development, and subsequent monofollicular and ultimately some single pregnancy and birth of a healthy born. So we should always start with the less invasive, simplest, and the cheapest treatment option. And that's why the role of IUI or the role of ovulation induction in a non-ART cycle plays a very important role. We need to maximize our singleton pregnancy chances and decrease in the OHSS chances and the multiple pregnancy. And that's the reason these are our basic goals of a ovulation induction. Now, another important thing we all need to know is patient respond differently to the same drugs. So we need to optimize our response and outcome and minimize the risk also. So remember one important thing. Don't think the same letrozole will work same way in all the patient. So how do we start ovulation induction? I decided what is my goal. I know that whether she's ovulatory and I'm stimulating to improve her subtle ovarian, follicular and luteal phase hormonal imbalance, to trim the IUI, or maybe I want to cause little super ovulation instead of 1, maybe 2 or 3 follicles. Or is it unovulatory and then my aim is to just stimulate and produce the egg, only 1 follicle. Now, before you do anything, important is analyze the reserve of the patient. Before starting the ovarian stimulation, 2 things we understood: select the correct stimulation protocol for that patient and define. So when your patient comes with their history, you have to come to this diagnosis in your mind. And then, so what are the various tests if I want to see the ovarian reserve? Biological, it means her chronological age. So first find out what is her age. Biochemical, mainly we do the static, which is either FSH, FSH-LH, and the AMH. I gave MMH in a red because MH now, the facilities are available even in the smallest city, and I may not do FSH, I may not do LH, but I'll definitely do the MH because it is independent on the day of a menstrual cycle. Then it may be a biophysical. By sonography, I can see the ovarian volume and the antral follicular count. So what we use routinely in practice is the age of the patient, AMH, the AFI, and also her BMI. And then we define our goal. Now understand one thing. In our non-ART, one growth, while in ART, multiple follicle. So we need a very specific and stringent monitoring. You never can give injections or the tablet information on a phone. Now, once you define the goal, anovulatory or normal cycle, the starting point is, remember one important, the threshold concept. If you understand that there is a FSH threshold and your level of endogenous or exogenous FSH together, the follicle doesn't understand the FSH has come from a pituitary or it has come from an exogenous. As long as the level in the blood, it is above the threshold. So what happens is sometimes even in IVF patients, when we start the stimulation, probably we may underestimate and we may give a dose lesser than the threshold and then none of the follicle rescue. But that cycle teaches us what is the threshold, FSH threshold of that patient, and we can improve subsequently. Same way, this threshold approximately we work out or we decide by the age, by the body mass, BMI, then her AMH level, and also her AFI. By that, we come to know what should be our FSH so that we can go above the FSH threshold of that patient. And the follicle, only one follicle we want to. What is the difference in ART? We keep on giving the doses for a longer period so we can rescue many follicles and we don't allow them to undergo atresia. So again, to revise, this is so important, and that's why I'm revising again and again. All patients, whenever you start the ovarian stimulation, may it be for a letrozole, may it be for anything, age of the patient, AMH, her AFC, and her body mass index, BMI, all play very, very important role. Don't do the fancy inhibin B or estradiol or other things which may not be. And as I said, indication for ovulation, most important thing is every patient who undergoes IUI. It may be IUI with oral ovulation or IUI with the injectable. You need to, when you are planning IUI, you need to stimulate the ovary. Don't plan IUI with the natural cycle, because IUI should be planned as near to the ovulation, and in natural cycle, it's very difficult to predict unless you are doing a very close monitoring on a LH levels. So any patients who needs a IUI, I have to go. Unexplained infertility, maybe it is a subtle follicular or luteal phase imbalance, and that's why it is unexplained. A luteal phase defect itself, or woman with the short follicular phase, or women with the anovulatory, that is PCOS. All these patients are indications for this. And that's why you can divide it into chronic anovulation, or it is a normal ovulatory woman prior to IUI, or a short follicular phase. Now, when do I start? I understand which patients I want to do. What is important is when to start. So I try to make it in one slide to understand you. This cohort is started on the day 1, day 2 of the menses, or with the new theories in a previous luteal phase only. The cohort starts by day 5, day 6, one of the follicle become dominant. This dominant follicle means what? The granulosa cells multiply, there is more vascularity, there is more FSH receptor, and there is more E2 value. And this E2, which is getting produced by the dominant follicle, goes and inhibits the pituitary with the FSH. If inhibition to the pituitary happens, the pituitary stops secreting FSH. The rest of this follicle, because of an insufficient FSH, will become androgenic. They will undergo atresia. While in the dominant follicle, because there is a more FSH receptor and more vascularity, there is a selective utilization of that FSH, and this dominant follicle alone goes. This is what happens in a normal menstrual cycle or routinely. Now, what is our aim of this ovulation induction in a IUI cycle is, even if I want to add on gonadotrophin before they undergo atresia. So you have to give a gonadotrophin. Suppose the patient is normal ovulating, she's unexplained, or she is for a male subfertility and for IUI, but you want to start her along with the oral ovulation gonadotrophins. I know everyone starts the oral ovulation on day 2, day 3, or in a PCOS patient, even day 5 makes no difference. But in this patient, as I told you, by day 6, day 7, when the dominant follicle gets selected, before these follicle undergo atresia, before they become androgen dominant, add on your gonadotrophin and you can rescue them. So whenever you wish to add a gonadotrophin in an ovulatory patient, it should be always before day 5, before day 6. So we always start on a day 2, day 3. While in a PCOS patient, where your aim is probably the dominant follicle, you are selecting with the oral ovulation and then you are pushing with the gonadotrophin, you may start it little later. So it depends upon whether you want to push the dominant follicle, you start after day 5, day 6, or if you want to rescue, then before they become androgenic, before they start the process of atresia, which is irreversible, you should be giving the gonadotrophin and rescue the follicle. So once you understand, let's talk about, so we understood when to start. Now, which are the drugs? These are the oral ovulogents, Clomiphen, Letrozole, Anastrozole, Tamoxifen, and these are the gonadotrophins, which can be highly purified HMG, highly purified FSH, or recombinant FSH. And in addition, I'll be covering with you in brief about the agonist and antagonist cycles also in a routine IUI. So what is the prerequisite? How do you call? Always call patient on day 2 or day 3 in your cabin and do the sonography and confirm that no follicle more than 10 mm is seen in the ovary. If I see here 2.5 centimeter follicle, it may be the remnant cyst of the previous follicle. And if I stimulate her, that follicle will become a big cyst. So always ensure that the follicle size less than 10 mm, whether PCOS or non-PCOS. So it is a down-regulated ovary, that is what we call. And if there is a cyst, we should not be doing any stimulation. So there has to be absence of ovarian cyst. And the endometrial thickness less than 6 mm. On day 2, day 3, if the endometrial thickness is like 1.3 mm, it means she did not have a good withdrawal. It means she definitely have a cyst inside. Always remember, they all go one together, and that's where you need to know that before starting, she don't have anything remnant from a previous cycle. So selection of a dominant follicle occurs early in a follicular phase, as I told you. So we should be initiating within 3 days of a menstrual cycle, and we should be doing the dose tolerance. So oral ovulation, Clomiphen. For decades, more than 5 decades, the Clomiphen is playing its own role. I'll be talking little bit on tamoxifen, and I will be talking also on aromatase inhibitors. What are the anti-estrogens now? First, Clomiphen citrate. So you can start on day 2 and you can give for 5 days, and you start the follicular monitoring usually from day 7 or day 8. There is no harm. Sometimes there can be a little exaggerated response and patient can reach to 16 mm on day 9 only. So it's one first sonography you can do on as early as day 8. And if the follicle is just 12 mm, usually these follicles grow with the rate of 1.5 millimeter per day. After 16 mm, 15 mm, they may go little more rapidly. So if it is 12 mm, then I know that another 2 days, 48 hours or 72 hours, I can call her next. So you can start and then you will do this. Now, pregnancy rate are same, whether you start from day 2, day 3, day 4, or day 5. So, doesn't make. Usually, you make a starting dose of 50 milligram because people have seen, and we all have seen OHSS even with the 50 milligram dose. So the first cycle always start with 50 milligram and then you can increase. Though the book says 150 to 200, believe me, I have never used more than 100 in my life. So, but if suppose patient is little bit obese, her BMI is higher, there's no harm you starting with 100 milligram. So the dose should be correlated with the body weight, with the age of the patient, with her AMH, also her AFI and everything. It's very difficult to predict precise dose of this oral ovulation. And you can do the empirical increment. Believe me, if 2 consecutive cycles, in spite of 150 dose, you got it unovulatory, you need to discontinue only Clomiphen as a treatment cycle. What about tamoxifen? Tamoxifen can be given. There are some who loves to give tamoxifen 20 milligram from day 2 or day 3. I used tamoxifen when letrozole was banned from the ovulation induction. Why so? Because it doesn't give a endometrial thinning. You don't have thinning of the endometrium, which is a big disadvantage of a Clomiphen. Tamoxifen doesn't alter the endometrial thickness, and that is the biggest this one. I have never given the combination of CC and tamoxifen, but there are few ART consultants who are using it. It is your choice. Now, most importantly, I have to make you understand Clomiphen, if you are giving, if there is no ovulation at all, no dominant follicle, we call it as a Clomiphen resistance. And when the ovulation has happened and still patient did not conceive, we call it as a CC failure. Now, when do I stop Clomiphen? I started. She's a virgin patient, came to me for the first time. No more cycles taken before. When 6 ovulatory cycles failed to yield a pregnancy, so favorable age group, everything is fine. At least you try 6 cycles, because if you don't try 6 cycles, in no time you will reach to gonadotrophine, laparoscopy, and then ART. In 1 year, patient land up for a IVF cycle. So please give a patience. Not necessarily every egg is healthy egg. Not necessarily that egg is genetically normal. Not necessarily you have given a trigger at the right time. Not necessarily she has kept their good relationship. So there may be so many things. What we see about the oocyte, only tip of the iceberg are the healthy oocyte. That is why the fecundity rate in the population is low, and give a lady the chance to try and conceive with the simpler treatment. If I don't get it, then I will not keep on. 6 cycles I have documented, they had relation, beautiful, I have monitored them completely, and still they did not. Then I need to think there may be associated other factor caused beyond the gametes. And in this all, I'm concentrating on an egg formation, release of egg, and release of the sperm in the reproductive system at the right time. I'm not concentrating on any other associated intrauterine pathologies, tubal pathologies, or pelvic pathologies, which may be hiding. So the cause beyond the gamete you should be looking at. Or when you can stop, when there is no ovulation, even with 150 milligram dose. Or endometrial thin. Can you see that? This is 3 millimeter, 4 millimeter, such a thin lining. Even if you have ovulated, she may not get implantation because of the poor deciduum. So you have to stop. That is what, again, I'm summarizing. Failure to ovulate. Maybe she has not ovulated. High free androgen index. Very important. And that is where you have to concentrate on a decreasing body weight. And that is why diet, exercise, weight loss is very important in a PCOS, which I covered probably in a last cycle, in a last meeting, completely only on a PCOS. There may be a high LH. There may be ovulation, but no conception. or it may be an anti-estrogenic receptor. Very early as 1990, Casper and his team has spoken about endometrial thinning happening between 15 to 50% of the patient. There is always estrogen receptor downregulation and depletion. And that's the reason why there can be these problems. Also, there can be a separation of a pinopod formation. These all play a very important role in implantation. And remember one thing, thinning of the lining is not dose related. It can repeat with the first cycle of 50 milligram also, and it can be with the repeated cycle. So improvement of the results with CC, if you concentrate on this, if she is overweight, do her weight loss, improve her insulin resistance. You may add on insulin resistance decreasing drugs like metformin and other. And if it is a high LH, you may give her OC pills before you start her stimulation. So you may get this high LH in a PCOS patient. So you give them a OC pill and then you start it. So you have to think about why my patient is not responding. And what is the treatment? Expand the diagnostic evaluation, think beyond the gamete, or change your treatment strategy. And what is the treatment strategy? You may give Clomiphen for 10 days if she is not ovulated. You may give sequential Clomiphen and Gonadotrophine. So add on Gonadotrophine. An alternative medication you can think about is either aromatase inhibitor, tamoxifen, or Gonadotrophine with or without GnRH. So very important, either add on Gonadotrophins, continue Clomiphen, or replace Clomiphen completely. Replace with either oral ovulation, that is aromatase inhibitors, with Gonadotrophins. Now, should CC be skipped in a PCOS, high BMI, elderly age group, AMH is very high hyperandrogenin. Can I screen? There is no evidence yet. But we all should be talking about letrozole now, because evidence is saying letrozole. Remember one thing, when letrozole came for ovulation induction, many publications has tried and proved non-inferiority of letrozole over Clomiphen. Then they started talking about letrozole as good as Clomiphen in even as far as multiple pregnancy concern, or it may be with the birth defects of the baby. And then we are now coming with the publication where letrozole is becoming a first drug of a choice for ovulation induction, especially in PCOS patient. So the conversion, I am not going to talk about the aromatase in how letrozole work, but you should know that it doesn't work on doesn't disturb the HPO axis, and that's why when even single follicle has started becoming, the estrogen value comes up, it will go and cause a negative feedback and decrease the FSH, and that's why we say it can cause a monofollicular growth. Its mechanism of action, as I told you, mainly it doesn't cause an inhibition with the HPO axis, and it locally, this is very important. Locally, what it does, it augments the follicular FSH receptor expression. So there is an amplified action of FSH because FSH receptors have increased. And this is also very important. It induces intrafolliculars high IGF follic concentration. Why? What does they do? They synergize with the FSH and they cause a better folliculogenesis. Now, what are the advantages? There is no adverse anti-estrogenic effect on the endometrium. This is very important. It doesn't cause estrogen receptor depletion. Also, most importantly is the half-life is just 2 days. Now, what is importance of this? And if you are shifting from Clomiphen to letrozole for a patient, one important thing I forgot to tell you with the Clomiphen, the half-life of Clomiphen is very high. So If you want to shift, patient had 3 Clomiphen cycle failure, and now you want to start with aromatase inhibitor, please give her a gap of 1-2 months, because the continuous effect of a Clomiphen on the system will be still there because of its larger half-life. While with letrozole, the half-life is very low. Then it improves the uterine blood flow, limited number of follicle because the HPO axis is intact, and hence decreased chances of OHSS and multiple pregnancy. Now, again, you can start from day 3, day 4, and 5 days, 2.5 to 5 milligram. Now, there are people who are doing single dose 20 milligram on day 3. I'm not tried that, but what I do is 5 days. I started from day 3 to day 7. On day 8, when I see there is no good recruitment, the follicle size may be only 9 mm or 10 mm, I tell the patient, don't stop the letrozole, continue for another 5 days. So extended letrozole regime can also be, and that's another advantage to start on day 3 and call the patient on day 8 for a sonography again. Now, after letrozole, what does this cockroach? This is what I want to tell you. Letrozole appears to improve the live birth rate and pregnancy rate in subfertile with the unovulatory PCOS. There is no defect, and Cochrane has said this again and again, and several publications have proven that letrozole may be the first line of therapy. Now, comparable results. Miscarriages, ectopic pregnancy, or the multiple gestation all becomes advantage. And Cochrane 2018, after this, has also told us that letrozole appears to improve the live birth and pregnancy rate in unovulatory, and there is a high probability evidence that OHSS rates are similar and no difference in a miscarriage rate and low quality. That's enough. Now, another very interesting study, why I took this study, and you should be knowing that certain countries, they have taken in their guidelines letrozole as a first line of treatment. I forgot to put that slide here, but the many countries have put in their protocols that letrozole is. This is a very interesting publication. Why? 14,500 cycles they have confirmed in 8,500. It's one of the largest single center study. And what they have done is, this is of course retrospectively, natural cycle IUI versus ovulation induction with Clomiphen, letrozole, and Gonadotrophine. And they compared in this the live birth rate. In natural cycle, of course, it will be lower than the letrozole, Clomiphen, or Gonadotrophine. All the three are similar. The multiple pregnancy rate in natural cycle, of course, it was less than 1%, but in their study, even in letrozole was as good as a natural cycle. And the cumulative birth rate with the natural cycle, as I told you, natural cycle IUI, very, very difficult to do to time the ovulation. And we all know that IUI should be done as near to the ovulation as possible. But cumulative pregnancy rate, they found with CC, letrozole, and Gonadotrophine, in fact, marginally more in a letrozole than even Gonadotrophine. And very importantly, they concluded that in an IUI program for unexplained or mild male fertility, ovarian stimulation with letrozole may significantly increase the live birth rate while controlling the multiple pregnancy rate, because it was only 1.3%. So in an ovulatory patient, when you are giving an ovulation induction, alone letrozole may be much superior than others. Now, you also should know what are the contraindications. Any patient with liver disease, renal disease, and naturally, if HPO axis is not working, obviously, you will not give a letrozole. This is about the now few comments on when I'm talking about the oral ovulation. Let me also talk about the metformin. Now, believe me, metformin or D-chiroinositol, these drugs are not to be taken as an ovulation induction drugs, but they can be combined in a patients of polycystic ovaries with oral ovulations or with gonadotrophins. But I give metformin in without CC and letrozole to which patient? Now, my patients, if I am putting them, PCOS patient, obese PCOS, I have put her on a 10% decrease in her BMI. Now, if her body mass has to reduce by 10%, and if she takes it seriously, I give them metformin also. It helps in decreasing the insulin resistance. I don't tell patient, but I know it may help little bit in decreasing the weight of the patient. And if she get ovulatory, she can conceive on her own. So adding the metformin is not for ovulation induction, but to reduce the insulin resistance. I do add metformin when my patients are on a diet, exercise, weight loss program. About D-chiro-inositol and all, one thing I want to tell you, there is no evidence still today that in PCOS patient, by giving these drugs, you will improve the result. But if you hear my previous talk on second Monday of a last, where I spoke hugely on all these drugs, in a PCOS patient, there are many promising publications which are coming, which shows very promising results with these drugs. And the combination with the 1 in 40 doses, it's giving better result. Maybe 5 years down the line, we will say, as we are talking with metformin should be given in a PCOS patient, we will be talking maybe D-chiro-inositol plays a very important role. What about metformin? The Cochrane review is saying this is what I'm talking about, the insulin sensitizing drug metformin in PCOS patient. They say there may be improved clinical pregnancy and ovulation rate with metformin and added to the Clomiphen than Clomiphen alone. And they suggested, please, in a PCOS patient, use combination. But when you use with oral Ovulation, you improve clinical pregnancy rate or ovulation rate. Whether it translates into the live birth rate, the Cochrane doesn't show the evidence. But if it is the addition of gonadotrophins, so if you are doing a metformin, can increase the live birth rate if you add on with the gonadotrophin. So if my PCOS patient, my CC failure or letrozole failure or resistance, and I'm adding gonadotrophin as a second line of a treatment, then metformin addition will help to increase even the live birth rate. So what I do in my ovulation induction for PCOS, I give letrozole and metformin both. And then if I have to add on gonadotrophin, of course, the metformin is there. I use metformin even with the oral Ovulation routinely. So friends, once we finished with the oral Ovulation, let me talk about few minutes for a gonadotrophins. Gonadotrophins for ovulation induction, very important. If you see the Cochrane from 2001, 2000 to Cochrane till 2015 here and further, recombinant and urinary both are equally effective. Whether it is a PCOS or non-PCOS patient, recombinant or urinary both plays a very important and equal role. So if you see the Cochrane 2011 ovulations induction with the anti-estrogen, gonadotrophins and everything, everywhere the birth pregnancy, it's on a right side and you have a better results. Now, ovulation induction protocol with the gonadotrophins, we all know you can just give a complication also. So you need a stringent monitoring. Day 2, I will always advise you to start oral ovulation with gonadotrophins when you are giving gonadotrophin, because you will increase endogenous gonadotrophin, and then maybe the doses needed for exogenous gonadotrophin will be less. So try to combine always the oral ovulation and gonadotrophins. Now, when we talk about gonadotrophin, second line of treatment, there are specific protocols. Again, mandatory to do the day 2 sonography and mandatory to do the close monitoring. The monitoring is not only for the follicle size, but also for the endometrial thickness. Remember this, very important. Sometimes you may have a good embryo formation, but the defect in this thin endometrium, refractory. It may be a Cox cavity. It was gone undetected. And you may be, because of evaluation of a refractory, patient was not on a Clomiphen. It was just the Letrozole and Gonadotrophine, and still her E2 value may be 800, but the lining is thin. It means there is some pathology in the uterine cavity. So when we do the monitoring, we don't see only the follicle, we see associated endometrial thickness as well. Now, if I have to add on letrozole, gonadotrophine, especially in PCOS, you know that low dose protocol, and after 7 days, step up to by 100% or by 75%, depending upon your choice, patient's BMI, age, and everything. What I want to tell you here is, this is what the books tells me. This is a chronic low-dose protocol. I have never given, frankly speaking, for 30 days, these gonadotrophine. These are given all in a book or the step-down protocol. Once I show you all these, I'm going to tell you what I am going to work with patient and what I do in my practice. First is HMG. The problem is the available ampules are 75 or 150. Maybe for an IUI patient, I use a recombinant because it is available in a pen form. So patient don't have to take half dose and throw off the half dose. If I want to titrate 37.5, I can do it with the pen because recombinant comes in a pen. Second thing is, once I educate the patient can take, they are so simple, subcutaneously, patient can take at home. So I pack up on day 2 when she comes, I do the sonography, I give her a regime, and I pack up the pen of a recombinant FSH with her. And I tell her, start from day 3, your oral ovulation, and maybe on day 4, day 5, I start with the 50 dose. Always I start with the 50 dose. And on day 9, I call. Now, on day 9, when I see the patient, if I see the follicles of 12 mm, 13 mm, I will tell her, continue the same 50 dose for another 48 hours and come for a sonography. I see 17, 18, I will continue for one more day, and I always give a trigger at 19 mm because many a times you have a fellows with her. The 19 mm, because even at 18 mm, you can give the trigger, and 20 mm also you give the trigger. It should be okay. So I give 1 mm margin of error for my fellows. And that's why in my center, we call 19 mm give. Of course, the Doppler study to see more than 70% is follicle is absolutely having a vascularity, indicates that it is pre-ovulatory. But also equally important is, if on day 8 or 9 I called, and if I see the follicle size of 9 mm only, I may probably step up from 50 to 75. And I will know that the pain may get over in another 1 day, because I may give her a pain of 300, telling her that 50 extra dose may be there. For a IUI, I don't give a higher doses pain because they are expensive. Now, if pain is over and the follicle from 75 has gone, with the 75 gone to 11 mm, I can put her on HMG. I don't have to worry about, because now I know her dose requirement is 75. And that is what the threshold concept I'm going to teach you today. You titrate your own doses. Don't believe these 7 days, 37.5, 7 days, 37.5 increment. That's very difficult. Very difficult. It's torture. And with the success rate of 6 to 18%, patient is not going to accept this for a long. So you titrate and come out with your own threshold concept. Now, if in this cycle, even if I increase the dose and I found that the follicle has not become dominant, it means probably her threshold is very high. I will give her a progesterone, take a withdrawal bleeding. Then next cycle, I will give her a break with the OC pill so that I don't have an intermediate follicles of 8 mm to 9 mm. And then I will start with the stimulation. Here I know her previous cycle threshold. I learned that 50 was too low dose for her. And I may start with the HMG from day 4. Now remember, when you start the gonadotrophin, try to give till the follicle become mature. You cannot stop in between the drug. People have tried to become cost-effective alternate day therapy. Tulandi has a beautiful publication where he has given alternate day, and he said his success rate, ovulation and pregnancy rate was less. But if you read very carefully, his article shows only gonadotrophin use. Now, if you are using oral ovulation, it means letrozole, you allowed endogenous gonadotrophin also to work. Then, even if you try and give an alternate day, in some patient, you may succeed. And when the follicle has gone above 14, 15, please continue everyday dose. So you have to behave yourself that I am a follicle. What do I need? How much dose I need? And then think about. Now, when you have a very low oligofollicular ovary, and you are taking her for IUI with gonadotrophin, your aim is to stimulate all the three. Your threshold has to be above so that you can rescue all the three. In a normal follicular, my aim is to rescue only two here, then my threshold will be low. I don't want to put it here, the same like before, and stimulate all these follicles. While in polycystic ovary, my threshold, my aim is, there are so many follicles, my aim will be just to rescue 2 or 3 follicles, so I will give still lower dose. So friends, when it is a PCOS, you may think about step up slow regime to avoid OHSS, to avoid complication, to avoid multiple pregnancy, or to avoid cancellation of IUI cycles or conversion to ART cycle. You learn yourself the threshold, and the threshold is decided by age of the patient, her ovarian reserve, which is seen by the AMH and AFI, and her body weight. These are the factors who help you to decide what should be the threshold. Very difficult to calculate this threshold. Sometimes your previous stimulation helps you to decide what may be the best threshold for that patient. So Cochrane again and again has said otherwise. There is no difference in a clinical pregnancy rate, whether you use recombinant or whether you use highly purified or whether you use a urinary gonadotrophin. When do you cancel? If the E2 value is above 800 or if more than 3 follicles are going above 14 mm. So I see 6 follicles, 14 mm on this. She has hyperstimulated. Probably her threshold, I gave a little higher dose. I may give a lesser dose and rescue only 1-2 follicle. I probably will cancel. More than 32, if more than 4 follicles about this, it is fine. But if the E2 value is very low, my stimulation is going on and patient is not responding, I need to call it a day. So these are the various reasons. Now, one trick I can tell you, suppose you have given and patient got 8 follicles, beautiful, 15 mm, next day 17 mm. You can do aspiration of 5 follicles and allow only 2 follicles to go. Usually we don't do because it is invasive, but if patient is not ready to get converted into ART, wastage of the cycle, because you need to give 1-2 cycles of a OC pill to make this follicle disappear, you may think of such rare creative ideas. Which ovarian stimulation to choose before IUI? Again, if you see the Cochrane says anti-estrogens appear to be cost-effective. Give oral ovulations first. When gonadotrophin is to be used, give it on daily basis. Don't give on day 5 and then just disappear. You cannot just rescue the follicle. You need to give a maintenance. Low dose protocols do not differ significantly in success when compared to high dose, which increases the risk of multiple and OHSS. And that's why I start with the low dose gonadotrophin. That is why I use recombinant only, because I can titrate little easily and I can pack up and I can avoid crowding in my OPD for the injections of an IUI patient. Role of GnRH agonist in an IUI, I'm going to cover it after this, but Cochrane doesn't give any evidence that it increases. There is no difference in probability of conception, whether recombinant or urinary. Both letrozole and CC are similar, though tamoxifen also has shown a better results. Now, last 5 minutes on GnRH analogs. What does GnRH analog does? Two analogs, GnRH agonist and antagonist. Antagonist directly suppresses, while GnRH analog will cause first flare-up and then suppression. So if the patient's cycle is going on, then you need to give only antagonist. But if it is pre-planned, then you can think about giving an agonist. So I'm going to show you why it is needed. Remember one important thing. The body also can give a LS surge. You may not give outside the body. Now, why the LS surge happen? Whenever more than 52 hours, the estradiol value of more than 400 remains in the body, there will be a LS surge. Now, the body doesn't recognize, the pituitary gland doesn't recognize that this estrogen is coming from 3 follicles, 150, 150, 150. Sorry, not 400, it is 250 microgram. So, if the pituitary blood levels of estradiol more than 250, the LS surge will start. But your follicles were 15 because together these 3 follicles have cumulative given a high E2 value. And that's why premature LS surge happen. With the premature LS surge, there will be luteinization, there will be progesterone effect on the endometrium. And that's where decidualization already starts and your embryo is not yet even formed. So you will receptivity window will be passed by the time embryo reaches in the uterine cavity. And that's the reason you should be using or you should be avoiding having premature LS surge. You understand? So in those rare cases, I, in my practice, give antagonist. When do I give? When I see the follicle, beautiful 3 follicles, 15, 15, 15, and beautiful lining. It's still the follicular phase lining, that is only with the estrogen effect. I will start her, and she's on gonadotrophin. I will start her on antagonist, and I will continue the gonadotrophin, maybe marginal increase in the dose of a gonadotrophin because I'm suppressing endogenous gonadotrophin completely. You understand? And then I will keep on moving. By this, I avoided premature LS surge. And that's why when you are doing a sonography and you saw 16 mm follicle, but you also saw the progesterone effect on the endometrium. That means the endometrium, the complete trilaminar pattern has gone. It became echogenic. That means the progesterone has started working. Believe me, whatever said and done, this patient is not going to conceive because her decidualization has started. By the time the egg will get released, embryo formation, and day 5, day 6, it will reach to the cavity, her endometrial receptivity window will be over and implantation failure will happen. And that's the reason you may think of giving antagonist or agonist. So as I said, if you have decided beforehand, then you have to start from day 1, low dose of agonist, and you have to give a FSH. So it is because it gives a flare-up. So this flare-up has happened before the patient gets the menses. And then when you add on FSH, continue this agonist, because afterwards it will cause an extended suppression. But when you started stimulation and that time you are finding that there are 3 follicles, and I do believe that she can have a premature LS surge, I want to give an antagonist, only can be given when it is unplanned and on the table you are taking a decision, because it will cause direct suppression. Until what time I should be giving? Till the day of a trigger. So till the follicle becomes 19 mm, all the follicles more or less between 18 to 20 mm you control. Now here you don't have to worry because all the medicine you have to give. Now, though Cochrane says pregnancy rate are higher with the agonist protocol, and they also said that with the antagonist, There are the very nice Ishre Capri workshop group who says antagonist they favored and ongoing pregnancy rate was 5% greater than non-antagonist cycle. While Cochrane doesn't believe, Cochrane says with the antagonist, there is no difference. But the live birth rate may be higher. Now, coming to one final thing in ovulation induction about the trigger. I already told you close monitoring, and the trigger I give at 19 mm with the margin of a 1 mm plus minus. But if patient comes and I measure 17.5 and her rate of growth in last two cycles, monitoring, I came to know on an approximately 1.5 mm. Today is 17.5 mm. I can pack up the recombinant SEG and I send her back home. Okay, tomorrow around same time, you take the trigger. I don't have to monitor. So sometimes you can intelligently utilize your time and patient's visit just by your experience and by your own monitoring. Now, which are the drugs we can give? One, SCG, 5,000 or 10,000. Give 10,000 if there is no 2 or 3 more than 2 follicles. Or recombinant, then only 1. And GnRH agonist if you are worried about the OHSS. You can give an LH trigger. Now, remember one thing. When you give a LH trigger, the life of LH is small. It will remain hardly for 48 to 72 hours. While SCG, when you give, it has an extended effect and it can itself work as a luteal phase support. It will remain for 6 to 8 days. By the time corpus luteum, and if the implantation happens, the complete corpus luteum can take over. So SCG may be of a more benefit than a GnRH agonist. What is the important role they do? So in every gonadotrophin cycles, I like to give the SCG triggers. Why? They cause a cellular and nuclear maturation, that is final meiotic resumption after the sperm entry, and follicular changes for follicular rupture and the ovulation. So it prepares the oocyte for a final stage. I'm just skipping the obesity. So summary, I'm going to go on a luteal phase support. So you gave a trigger. Do you want to give a luteal phase support? Friends, if you have used a gonadotrophin, there is always a luteolysis. And please give these patients the progesterones. The gonadotrophin, whenever you have used, progesterone luteal phase is mandatory. Now, we will be taking a complete separate series on a luteal phase support, so I may not discuss now. And before I end, very nice review article and the Ishre global recommendation. So the question and the answers. When is the ovarian stimulation required in IUI? In couple with unexplained and men with the less than 10 men with the up 10 million count, IUI should be combined with the stimulation to improve the live birth. So in all, so even if she is ovulatory, here what they mean is in an ovulatory patient, do you need it? Yes, you need it to improve the result. How can you prevent multiple pregnancy rate? There are many options you can prevent. In order to prevent the high-risk multiple pregnancy, you can withhold IUI more than 2 dominant follicle, moderate evidence. You can, when gonadotrophins are used, regimens with 75 or lower should be used because higher dose can give similar pregnancy but increase multiple. I have already told you, low dose or high dose, the pregnancy rates are same. CC or tamoxifen are acceptable alternatives to the gonadotrophin for low multiple pregnancy and birth rate with lesser. So you can think about how can you avoid, always start thinking up with the oral ovulation as the first treatment and keep a gonadotrophin for a second line of treatment. Addition of an agonist, not recommended. Good clinical point practice, alternative to cycle cancellation, I just told you, aspirate the excess follicles at the time of a surge so that the egg will not be released. You have just aspirated those follicles, but you allow 2 follicles just to rupture on their own. So friends, first line of treatment, always letrozole, CC, or tamoxifen. And second line of treatment is low-dose gonadotrophin. Low-dose gonadotrophin, you have to remember. So in infertility, individualization of each case is important to ensure excellent results. Friends, I think I try to simplify ovulation induction. I always like to thank my entire team, because without team, you cannot manage your day-to-day practice. That thanks to the team that we get persistently very good results. Thank you so much. Thank you for your time.